Good morning, everybody. And I'm going to talk to you about what we look for when performing a vascular assessment. I came last year and spoke about venous intervention in a workshop and obviously survived that. And then Ellie asked me to come back this year and gave me the title that's before you. So I kind of had a thought about what does this involve, really. And from my point of view, it's about going back to the sort of fundamentals. I don't like the word basics as such, but it's really going back to the fundamentals of assessment. And also I've taken out the words, what are we actually looking for? So it's regarding sort of inspection as such. And hopefully by going back to the sort of fundamentals, what hopefully we can do is look in a sort of taking a systematic and logical approach to clinical assessment from a vascular point of view. Appreciate that we do lots of other forms of assessment, but I think the vascular assessment is very key, and often it's seen as particularly arterial assessment, but it's actually also a venous assessment. So I'm going to look at arterial and venous. I've separated them apart, but essentially, perhaps from my point of view, we'd almost do them together. So I hope it makes sense. I hope we're all sort of have great knowledge, so I hope nobody finds it as sort of going back to the basics, and hopefully we can learn something from that and move on. So I set some simple objectives really for today, and I wanted to define really what we mean by vascular assessment and really what's seen as best practice, what should we be doing. And also the other thing is really, are we getting it right? There's papers and there's literature around there that perhaps we're not getting it right. And the fundamental thing is if we don't get the assessment right in the first place in the consultation, then we're going to fail to do the rest of it. It's a bit of a domino effect. And a lot of the literature that's around there sort of skates over sometimes the assessment process. So I wanted to perhaps define this assessment process a little bit further and really what are the sort of key skills involved and how can we make that a step-by-step approach. I haven't made it into a sort of an OSCE type presentation, but I wanted it to be in a logical, systematic approach, really. So I wanted to sort of put together what are we examining for clinically and really the implications of what we're finding. So I hope it's of use to you. So vascular disease, it's one of the many disease processes that can lead to lower limb ulceration or lower limb disease. And it's something that's incredibly prevalent, especially venous disease in the lower limbs. So I really predominantly perceive them as both chronic disease processes that are potentially progressive, and with age, they become more prevalent as well. And they can present independently. Patients can have either arterial or venous disease. It can also be mixed disease and other comorbidities. So from our assessment point of view, we need to identify the existence and also the extent and the relevance of the disease processes there. And also I was talking about a sort of continuum of disease process, and I want to present venous disease as a continuum of a chronic disease process, and really ulceration is the end point of those. And that picks up on several of the themes from the workshops yesterday, so I felt it was quite a sort of positive step forward. So best practice really with a patient with a wound really is to achieve a good and perform a good holistic assessment that identifies the wound causality and associated morbidities and also allows effective management. So there's a lot written over time, and I think the main question to ask is, are we getting it right? Well, we would like to think so, that we are getting it right. I'm sure that you're all working and performing and achieving excellent practice. However, there is quite a lot of evidence out there to say that perhaps we're not. And the sort of current prevalence, the recent figures by the guest team really show that ulcer prevalence is at about 1.5%, so it's about 1 in 170 adults. And with the prevalence of chronic wounds set to increase by about 12% each year, the problem is not going to go away. So we've got to make sure that we're getting lower limb assessment absolutely correct. And we know from the guidelines, signed guidelines that have been around for sort of 7 years, that patients require a vascular assessment to assist in the diagnosis, which quite often boils down to just performing an ABPI. And I think there is a lot of information that we can actually get before we actually go and perform an ABPI. And that often then dictates the level of compression. The burden wound study, which was spoken about last year and has been around for a while, raised important issues regarding the management of chronic wounds in the UK. 30% of wounds lack a diagnosis, so we're perhaps not diagnosing wounds etiology effectively, and 16% of patients had an ABPI, and yet 81% were treated with compression. So ABPIs are perhaps not as prevalent as we felt. So we need further strategies really to improve the provision and accuracy of diagnosis. So that goes back to getting the assessment right in the first place, and we need a detailed, holistic, individual assessment, and an accurate diagnosis really are the key. And we need care pathways which are developed and implemented to optimize the patient care, reduce the variation, and improve the patient experience, because they're the fundamentals. I'm not going to dwell too long on this because somebody else may allude to this. The NHS right care scenario, Betty's story, I don't know if people have heard of that or have looked that up. It's a fictional story. It tells the story of Betty, a patient with a lower limb ulcer, in a suboptimal pathway and also an optimal pathway, and this is freely available online. And basically, she doesn't have a diagnosis, she doesn't have any real form of vascular assessment, so her care, her ulcer doesn't really heal, but there also is the optimal pathway where she has a decent vascular assessment. They look at perhaps treating the underlying veins, and the costs both to Betty are much better with the optimal pathway than the suboptimal pathway. So if you haven't looked at that, I think essentially, although it's fictitious, I think the key thing about it is actually getting people to discuss, are we doing it correctly? Is this the right way forward? So if you haven't seen that, I'd urge you to go and have a read of that. So with timely diagnosis being the key, we've spoken about the sign guidelines, talking about holistic assessment, undertaking an ABPI, and starting compression in the community. As I was alluded to yesterday in one of the presentations, NICE, under their guidance 168, under the guise of varicose veins, decided that patients with lower limb ulceration and symptomatic veins and skin changes should be referred for duplex imaging, multidisciplinary treatment planning, and targeted arterial and venous intervention. That's within secondary care. And if the services aren't there, then we need to be looking in secondary care of providing those. However, varicose vein intervention is something that's often been targeted by sort of commissioners, seen as low value, but I think patients with venous ulceration and treatable venous disease deserve to receive timely intervention within the NHS. And there's nothing low value about having lower limb ulceration from the patient's perspective. So vascular assessment, why should we undertake that? Well, as practitioners, as nurses, we have a professional accountability, both in law and also to the patients that we are caring for. So we really want to evaluate the underlying vasculature from an arterial and from a venous perspective, and try and reach an accurate, effective differential diagnosis. We've always undertaken a vascular or arterial assessment to assess the suitability for compression therapy, but we also need to see whether there's a requirement for a form of venous intervention and also arterial intervention, as there are more modern available treatments for patients with superficial venous disease. So before any clinical assessment is undertaken, we need to do a holistic or global consultation, and it's really the initial phase of any form of clinical assessment. And the key thing from my perspective really is the important opportunity really for the patient to tell their story. That's where the golden nuggets of causality, how the lived experience of having an ulcer is there. So that's the golden sort of 5 or 10 minutes that the patient can really tell their story. You then, as clinicians, can start to use specific questioning to elicit vascular symptoms and also to expand on the history. And it's, from my perspective, it's a valuable opportunity to start to examine the patient's sort of ideas, concerns, and expectations, because ours as clinicians may be very different from the patient's. And if we're going to meet those needs, then we need to know exactly what the patient feels, what their sort of hopes, thoughts, and worries are about having lower limb ulceration. All of this, everyone is pressed clinically for time. It could be seen as time-consuming, but we really do need to get the basics, the fundamentals. I don't like the word basics, the fundamentals correct. So it has to be based on sound principles. So how can we effectively assess the lower limb, and what are we looking for exactly? As I've said previously, the key thing really is about getting the patient to release their story, to give their story, and maybe I'm going to look slightly later at venous symptoms. I look really at arterial symptoms. A lot of patients will describe what we call intermittent claudication, where they get pain in their calf, thigh or buttock that is quite repeatable, quite predictable and quickly relieved on rest. That's if the patients that we're seeing can walk, or the individuals that we can see can walk that far to actually bring that on. And then the other common symptom that patients complain of is ischemic rest pain. So it's, again, predictable, repeatable pain with elevation of the limb on night, specifically usually of the toes or the foot. And they often then stop sleeping in bed. So when the patient's telling their story, we can be thinking of perhaps differential diagnoses and then specifically ask questions to take a more detailed history. We'd be, if we were expecting patients to have arterial disease, looking and thinking, have they got a history of coronary artery disease, stroke, diabetes, smoking, all of these factors that can increase. Peripheral arterial disease is a systemic condition, so it increases the risk. So we need to take a detailed history, a drug history, allergy history, and also a social history to build a full picture. What I've tried to do is break down clinical assessment into straightforward systematic stages, and the title of the presentation was called What Are We Looking For? So lo and behold, the first thing that I've chosen really is inspection. Do we actually see what's in front of us? Do we take enough time to listen, to inspect to what's going on? Then on to palpation. So using our fingers to actually feel the structures, but we're actually looking and comparing before. So what's the same, what feels different? And obviously the obvious thing that we may be palpating are lower limb pulses. And it provides really valuable information to assist us in coming towards an accurate diagnosis of what's going on underneath. The other following on technique would be auscultation to listen. We can do that, and we often do that in practice with a handheld Doppler, which gives us a great deal of information. We can also listen to arteries and other areas of the body with a stethoscope as well. That allows us to hear stenoses and what we call bruits there. So arterial assessment, I've broken it up into arterial and then into venous assessment. Any form of assessment, we need to consider, patients having a chaperone. They need to understand what we're doing, so consent, warmth, any pain that the people have got. And I think often we're quite keen to sort of rush in and sort of touch and talk to our patients. But again, it's about standing, observing, looking at the individual as a whole, and then looking at the lower limbs in particular. So we do need to expose the patients. We do need to compare one limb with the other. And to do an arterial assessment, essentially patients are laying on the couch. We'd look at their sort of body habitus. We'd perhaps count their toes, look in between their toes. We'd lift the limb, look at the heel, and look at the posterior aspect. So we're getting a full view, and that gives us an awful lot of information. So we'd be looking at the colour of the tissues, looking at the pallor, looking for any necrosis, any erythema, looking at peripheral edema. We spoke yesterday about trophic changes to the nail, hair loss, fungal infections, scars from previous surgery. Maybe patients have had their long saphenous harvested for coronary artery bypassing, any ulceration. I'm not going to go into depth about ulceration assessment today, but what's different, what's changed, what are we seeing that's not perhaps normal clinically? And we're lucky with a lot of patients, although some arterial patients have lost their limb, that we've actually got another limb to compare it with. So it's important that we expose both and we compare one with the other. Moving on to palpation, we're going to assess the temperature of both limbs, ideally to do that at the back of one hand, and then work from sort of proximally to distally, comparing the limbs. Is there a difference in temperature? Is there a difference in capillary refill time? Is it increased? Which could indicate the presence of peripheral arterial disease. And also as well, from a vascular perspective, we would look at the pulses working proximally, so from the upper limb, from the groin, and working distally. So we're looking at the perfusion of the whole limb, and obviously not just distally at the feet. And with pulses, we'd be looking at the rate, the rhythm, the character, and the symmetry, and we'd move from side to side comparing. So as a control, we'd obviously check the radial pulse to compare what the radial pulse is like with the rest of the pulses and with the lower limb. What I haven't alluded to or looked at is abdominal assessment, looking at the aorta and feeling for aneurysmal disease, because that's something that we'd initially do. So I've kind of moved on to looking at the femoral pulse, which dictates the inflow into the lower limb, and I've marked the landmarks, essentially the knobbly bit on the pelvis, the anterior superior iliac spine, and the pubic symphysis, which is the pubic bone midway on the crease is the femoral pulse, and that's quite easy to palpate. And if a patient's got a good femoral pulse, then they've got a good inflow into their leg. If it's weak, then they've probably got some femoral arterial disease. So if the flow's poor at the top, it's possibly going to be poorer even below there. So it's quite an easy pulse to feel, except in very large obese patients, and the patients need to be laying fairly flat. So that gives us as clinicians some idea of the inflow into the leg. The next pulse working down is the Popliteal Pulse. It's perhaps not the easiest pulse to feel, but if we flex the limb to 30 degrees and wrap our fingers around into the popliteal fossa and put our thumbs over the tibial tuberosity, you can quite easily feel the popliteal pulse there. If it's really easy to feel, then potentially the patient could have a form of aneurysmal disease, but it gives us some idea of flow below the knee, and the artery is then split into three. So it's often a pulse that we don't talk about, but certainly from a vascular perspective, it's something that we would look and feel for. Probably the ones that we're familiar with, and I've obviously included them for completeness, is the posterior tibial pulse, which again, from the photographs, sits about 2 centimeters behind the medial malleolus, which is about there, and that's a little bit of a closer up one there. So this again is on palpation, and then the dorsalis pedis pulse, which is probably the one that people are most familiar with. And the landmark for that is the extensor hallucis longus tendon, which is the big tendon that is prominent from the base of the big toe, and the dorsalis pedis pulse sits lateral to that, and that's a good, it's almost between the first and second metatarsal, but that's a good landmark to find it over the cuneiform bones there. If we found them or we haven't found them, then we go on to use a Doppler to look at the sort of volume, rhythm and character. And there was a good talk last year on ABPIs, and I'm not going to cover ABPIs, but the signals that we would listen to would be sort of triphasic, biphasic or monophasic. With time, the arteries become less elastic, so the idea is that the pulse may become monophasic, and that may indicate some form of calcification or arterial disease. And also the popliteal and the femoral pulses can be listened to with a stethoscope to give some idea of the flow within them. I've included for completeness something called Berger's test, which has been around for quite a while, and it's a good sign if patients have got perhaps critical limb ischemia. It's quite a simple test that we could do clinically. Obviously, we need to make sure that the patients have got no significant back pain or lower leg pain, because raising the legs can cause back pain, and we need to explain what we're doing. So we'd lie the patient flat, and we'd elevate the non-effective side, raising the leg to about 45 degrees. If the limb goes pale, we're draining the leg of blood, and we're wanting to know really at what angle does capillary refill time slow down. So you'll see the limb go pale. If you repeat on the other side and then swing the legs to the floor, you can see on the image on the left there, the foot has become quite pale, and if you swing the leg to the floor, you get this hyperemia, this what we call sunset foot, where you've got metabolic products building up in the foot as the body tries to get rid of them with capillary dilatation. And that's a really clear sign that people have got quite significant peripheral arterial disease, what we describe as critical limb ischemia, if they haven't got tissue loss already. And that's something, again, before we've even gone down the route of doing our ABPI, we've got some idea of the flow through the limb and some idea whether they've got significant disease, which probably needs input. And again, probably the story from our patient will dictate what's going on. So arterial assessment really should identify the presence and also the extent of the peripheral arterial disease, and it really provides a sort of good indication, a good level, before we would consider doing our ABPI or undertaking perhaps in secondary care a duplex scan. So I think from a vascular perspective, we're not necessarily using ABPI just as a diagnostic tool. It probably supports our clinical decision. It's not 100% reliable. Patients with calcification, it essentially provides an index and adjunct for us, so it's not something we 100% rely on. So with venous assessment, and this is very much a sort of overview because it's only a short period of time and I haven't got all day and we haven't got all week, so it's very much sort of skimming the surface, but what I'm trying to do is present things in a sort of fairly logical way. Venous disease, again, we've looked at the arterial inflow into the leg, we're looking at the outflow in the leg, and I'm not really going to discuss the lymphatic system. We had discussion yesterday about the lymphatic system. Venous is about veins and returning blood back to the heart, and this is going back many, many years ago And Hippocrates said really patients with varicose veins should avoid standing, and that really is the problem when you've got the blood flowing back down again. So when we're taking a history, patients with venous disease or with varicose veins clinically give you an awful lot of symptoms, some of which they'll put down to their veins, some of which are clearly not venous in origin, but there seems to be a sort of positive association really between chronic venous disorders and leg symptoms. Common symptoms that patients report are sort of itching, heaviness, tightness. They're the sort of most closely associated conditions. Patients often talk about muscle cramps, restless legs. We don't really perceive them as venous symptoms, and they're sort of separate conditions and treated very separately. So the venous symptoms are often relieved by elevation, compression, the use of emollients. And when we're taking a history, we would be looking for sort of previous history of ulceration, perhaps venous intervention, history of DVT, lower limb fracture, or joint replacement. So this was again mentioned yesterday. Chronic venous insufficiency, it's a progressive condition, it's a chronic condition. When you look at the NICE guidance, it talks about varicose veins, it talks about ulceration, but not everyone with varicose veins develops ulceration. Not everyone with ulceration has varicose veins. They may well be hidden, but it is essentially a progressive condition. And the CAP classification, it's not a score, it is really just a clinical scale, does actually begin to put across the idea that it is a progressive condition. I'm not going to linger too long, but essentially C stands for sort of clinical signs, and you've got C0 there, which means that they've got no clinical signs of venous disease, and then they develop small thread veins, which we'll look at in a moment, visible varicose veins, a bit of edema with their varicose veins, some skin changes, which we'll also talk about, and there's at 5 a healed ulcer, and then at 6 an active ulcer. So it gives, all I want really people to do is to get the idea that it potentially could be a progressive disease. Not everyone gets to 6. Some people stop at various conditions, but at various stages across there, but potentially it is progressive. So if we're going to examine somebody from a venous perspective, and when you look at a lot of lower limb assessment guidelines, they don't talk a great deal about how we would assess somebody from a venous perspective, but I'm just going to sort of put perhaps how I would, or how we would do things. Again, really, arterial assessment, the patient was on the couch. From a venous perspective, we're talking about Hippocrates, about standing up. We need to get the patient to stand up. We might see varicose veins when they're laying on the couch, but that's not the right environment to do so. We do need to stand them up. It makes a big difference. And what we also need to do, none of this lifting the leg and peering at the lower limb or the ulcer on the lower leg. We do need to expose, obviously with dignity and privacy, the whole limb. So we need to look up to the groin level. And obviously, then what we can do is look at the front, the sides, the back of the leg, and we can ask patients to turn around, and we can compare and contrast. And obviously with the picture that I've got there, there's a clear change going on here. If we've got some disease in one leg, there may well be some early disease in the other leg, and if we're asked to look at that leg, it may be that we need to do something about that leg as well to prevent any problems. And often we're referred one leg, but actually there's a person and there's 2 legs, so we need to look at all of them and both limbs. So there's lots of things we can look at. We can look at the calf muscle bulk, that's important, the limb shape, are there any changes, signs of chronic venous insufficiency, which we'll go through in a moment. Edema is a whole nother field. Again, what have they got edema, and is that fairly new edema? Is it chronic edema? As we were saying yesterday, lymphedema, are there varicose veins there? And generally looking at the skin and other related venous changes. So there's quite a lot that we can just see from inspection before we start touching the patient themselves or looking at any wounds that are there. So just a quick walk through really the sort of signs of chronic venous insufficiency, and for a lot of people this will be revision, but I think it's important just to run over those really. And something which you see quite often is, and if you probably look at your own ankles, there's probably some sign, is what we call ankle flare, little intradermal veins with increased capillary pressure. Pop the limb in the air, they often sort of disappear, but then they recur. Cause patients a lot of concern. They don't cause any particular symptoms, but it's a sign that under the skin there are changes going on. So that's something that we'll often see on lower limbs. We'll often see some ulceration around there. So that's a key sign to see. There isn't any specific treatment other than sort of skin care, compression for that, but it's a sign that people are moving along that continuum. Varicose eczema, Again, when you've got proteins, amino acids with flow down veins coming into the skin starts to change its integrity. So we end up with dry, itchy, flaky skin, which is often treated fairly conservatively. And what we need to ask, is there an underlying problem there that needs addressing? We commonly see hemosiderin staining over here, where we've got red blood cells extravasating through into the tissues and breaking down with hemosiderin deposition, and that's almost changing onto lipodermatosclerosis, but that's a very common sign. We may see, and we can see on there some ankle flare down there as well. So lots of venous changes. That person is moving along that CAP classification, and we quite commonly see little atrophic white tissue, and if you look very closely, you can see star-like capillaries on there. Again, that's very fragile, sort of pre-ulcerative tissue, which is highly likely to break down unless we step in and do something either conservatively or interventionally. Varicose veins, those poor malign things that the NHS seems to be a little bit reluctant to do very much about. So from a palpation point of view, looking at the skin temperature, lipodermatosclerosis, which I'll come on to in a moment, essentially we need to palpate. Although we may see the signs of, we actually diagnose that on palpation. We need to feel the skin. Is it soft? Is it hard? Is it indurated? And with varicose veins, we may see them, but we do need to palpate their course. So where are they coming from? And also we need to palpate any edema that's there. Not going to linger too long on varicose veins, but they are a common sign of chronic venous insufficiency. They're dilated bulbous veins, result of venous incompetence, so you've got downward flow in the vessels. But the key important factor is that you may not always see them. You may palpate them, but you may not always see them. And some patients don't have any significant underlying venous disease, and they may also have some deep venous disease. So that's really where further investigation with duplex. But we should palpate them for warmth and tenderness. If they're hard and sore, then the patient's trying to treat themselves. They've developed some form of phlebitis. And essentially long or great saphenous varices, usually seen on the medial calf and thigh, originate in the groin, and short saphenous varices originate from the popliteal fossa behind the knee. And I'll demonstrate that. Here we've got some long or great saphenous veins coming down from the groin. They're associated with no skin changes. Sorry, the foot's not missing, is missing. And there I put the C2, C4, so they've got some skin changes there coming down. And that's the posterior aspect of the calf. And that's short saphenous veins on the back originating in the popliteal fossa. So we do need to stand them up, we do need to palpate them, we need to look for their course. And again, duplex ultrasound would tell us where they are. And if they're associated with some form of skin change, then we ideally do need to be thinking about intervening. A quick little video here. If we've got a minute, will this play? Yeah. Hopefully there's no sound on this. A little video that I did in clinic. It's me there, just doing a very simple inspection and also very simple palpation. So what I'm simply doing is asking the patient to stand facing me, and then all I'm doing is just palpating the course. That's the long saphenous vein coming down the medial aspect of the leg, and you can clearly see some skin changes. I'm palpating just the skin with my fingers, just feeling how hard or woody or indurated it comes to the lower limb. And then simply looking, veins can come across the thigh, what we call anterior accessory thigh, just asking the patient to turn around, and then looking at the back of the leg first of all, and then just looking and feeling in the popliteal fossa behind at the back of the knee, and then just palpating down the leg, just feeling the course of any varices there. We may not see them because of edema, because of hardened tissue, but when we feel the skin, we will feel them there, and certainly on standing they'll become more prominent. So I thought hopefully that just illustrates what I meant. Anyway, a little bit about lipodermatosclerosis, and we've almost done. Again, scarring of the subcutaneous fat is part of that continuing change. The skin really does change, and we often have heard the term inverted champagne bottle legs, when you get that disproportionate, that narrow ankle. Although the signs may be visible, we really do need to be palpating that skin to actually diagnose that. And again, there's some pictures here of that classic skin change that's occurred down there. And it's pretty much here pre-ulcerative, and it's very likely to ulcerate unless we do something. For completeness, I've included obviously healed ulceration here, and you can see some hemosiderin staining, you can see some ankle flare, you can see some early induration of the tissues, and again, all of those signs are present there with active ulceration. So if we look beyond the ulcer, we can see all of those signs. Not going to dwell too long on venous duplex, but with the venous system, we've talked about superficial venous disease. Patients have deep veins, a large amount of the blood goes up the deep veins. If they've had a deep vein thrombosis, they may well have very poor outflow of the leg. So the only way that we can actually assess that, and also the need for long-term management, is to actually perform a duplex scan. And that gives us quite a lot of information. And as was discussed yesterday in one of the sessions, was talking about treating the superficial venous incompetence, and that's something that we can now do. So with venous disease and assessment, it highlights the underlying sort of venous pathology and really does help to sort of facilitate a differential diagnosis. And we can see when we've seen patients clinically how far along that continuum they are, and if they've got active ulceration, if they're at risk. NICE recommends referral to a vascular specialist in secondary care. Those services may not necessarily be that well developed. There may be a delay, but it means therefore that we need to improve those services. There are quite a lot of patients that would benefit from modern venous techniques, the endovenous techniques. They've been around for well over 10 years. They don't require general anaesthetic. They're very much walk in, walk out. It was what I sort of spoke about last year. So we don't need to necessarily rely on conservative management for these patients. There is an option of interventional management for them. There is, just very briefly, because time is ticking away, nobody yet has mentioned the Everest study, the early venous reflux ablation. It's an NHS study. It's simply looking that should we be offering patients with active venous ulcers endovenous treatment before the ulcer healing. It's traditionally felt that we should treat the underlying venous disease once the ulcer is healed. We know that intervention prevents recurrence in healed ulcers, but does active treatment speed up healing? So that's the primary endpoint of this study. It's a randomized controlled trial. It involves 500 patients. The results from this will be released next year. Obviously, having been involved with this, I obviously don't know the outcome from the study. I'm not privy to that, but obviously looked at some of the data that was looked at sort of screening as such, and about 30% of the patients that were referred had ulceration for greater than 6 months. So it shows perhaps that we're not referring the patients within that sort of 2-week window. But equally wise, it may well be that the services in secondary care are not able to see patients that quickly, and there is a delay in getting patients in. But anyway, this is around the corner. This may hopefully increase the possibility of endovenous treatment for patients. So in summary, to conclude really, ulceration perhaps is the endpoint of continuum of chronic vascular disease processes, whether that be arterial, venous, or both. Timely vascular assessment really is fundamental for effective management, and it also helps us to facilitate sort of differential diagnosis. And it really also as well highlights the requirement for vascular intervention. And coming back to vascular intervention, I think as clinicians and for the benefit of patients with lower limb venous ulceration, we need to continue to challenge passivity in lower limb venous management. And just going back to Ellie's original title, which was about seeing what's before our eyes, I found that little quote. The hardest thing sometimes to see is what's in front of your eyes. So it goes back to the value of inspection before we go on to palpation and auscultation. So hopefully that's presented things in a fairly logical, systematic way. So thank you very much.